Hello class, welcome to Chapter 31, Orthopedic Injuries. After students complete this chapter and the related coursework, they will understand the anatomy and physiology of the musculoskeletal system. They will have learned the proper assessment for a suspected and obvious injury. They will have learned general and specific types of musculoskeletal injuries, including fractures, sprains, and dislocations, with associated signs and symptoms and emergency treatment, including the use of splints, the PASG, and the traction splints. Introduction. The human body is a well-designed system in which form, upright posture, and movement are provided by the musculoskeletal system. The system also protects the vital internal organs of the body. The bones and muscles are susceptible to external forces that can cause injury. Also at risk are tendons, cartilage, and ligaments. Musculoskeletal injuries are among the most common reasons why patients seek medical attention. Musculoskeletal injuries are often easily identified because of pain, swelling, and deformity. Although musculoskeletal system injuries are rarely fatal, they often result in short or long-term disability. Do not focus solely on the musculoskeletal injury without first determining that no life-threatening injuries exist. Anatomy and physiology of the musculoskeletal system. The muscular system includes three types of muscles: skeletal, smooth, and cardiac. Skeletal muscles, also called striated muscles because of the characteristic stripes, attaches to the bones and usually cross at least one joint. Called voluntary muscle because it is under direct voluntary control of the brain, responding to commands to move specific body parts. Skeletal muscle makes up the largest portion of the body's muscle mass. All skeletal muscles are supplied with arteries, veins, and nerves. Blood from the arteries bring oxygen and glucose and nutrients to the muscles. Waste products, including carbon dioxide and lactic acid, are carried away in the veins. Skeletal muscle tissue is directly attached to the bone by tough, rope-like fibrous structures known as tendons. Tendons are extensions of the fascia that cover all skeletal muscles. Smooth muscle performs much of the automatic work of the body, also called involuntary muscle because it is not under voluntary control of the brain. Found in the walls of most tubular structures of the body, such as the gastrointestinal tract and blood vessels, contracts and relaxes to control the movement of the contents within these structures. Cardiac muscle composes the heart and is a specifically adapted involuntary muscle with its own regulatory system. The skeleton. The skeleton gives us our recognizable human form, protects our vital internal organs, and allows us to move. Made up of approximately 206 bones. The bones also produce blood cells in the bone marrow and serve as a reservoir for important minerals and electrolytes. This figure on this slide illustrates the human skeleton. The skull is a solid vault-like structure that surrounds and protects the brain. The thoracic cavity protects the heart, lungs, and great vessels. The lower ribs protect the liver and spleen. The bony spinal canal encases and protects the spinal cord. The pectoral shoulder girdle consists of two scapula and two clavicles. The scapula, or shoulder blade, is a flat triangular bone held to the rib cage by powerful muscles that buffer it against injury. The clavicle, or collarbone, is a slender S-shaped bone attached by ligaments to the sternum on one end and to the acromion process on the other. The clavicle acts as a strut to keep the shoulder propped up. Because of it is slender and very exposed, this bone is vulnerable to injury. The figure on this slide shows the pectoral girdle and the anterior view and posterior view. The upper extremity extends from the shoulder to the fingertips and is composed of the upper arm, humerus, elbow, and forearm, radius, and ulna. The upper extremity joints, the shoulder girdle, and the humeral joint. The humerus connects with the bones of the forearm to form the hinged elbow joint. The radius and ulna make up the forearm. The radius, the larger of the two forearm bones, lies on the thumb side of the forearm. The ulna is narrow and is on the little finger side of the forearm. When one is broken, the other is often broken as well. The hand contains three sets of bones: wrist bones, carpals, hand bones, metacarpals, and finger bones, the phalanges. The pelvis supports the body weight and protects the structures within the pelvis, the bladder, rectum, and female reproductive organs. The pelvic girdle is actually three separate bones fused together to form the intimate bone, the ischema, ilium, and pubis. The lower extremities consist of the bones of the thigh, leg, and foot. The femur, the thigh bone, is a long, powerful bone that connects it in the ball and socket joint of the pelvis and in a hinge joint at the knee. The femoral head is a ball-shaped part that fits into the ischium, connected to the shaft by the femoral neck. The femoral neck is a common site for fractures, especially in the older population. The lower leg consists of two bones, the tibia and fibia. The tibia, or shin bone, connects to the patella, kneecap, to form the knee joint, and runs down the front of the lower leg. The much smaller fibia runs behind and beside the tibia. The foot consists of three classes of bone: the ankle bone, tarsals, the foot bone, metatarsals, and the toe bones, phalanges. The largest of the tarsal bones is the heel bone, or calcaneus, which is subject to injury with axial loading injuries, such as when a person jumps from a height and lands on the feet. The bones of the skeleton provide a framework to which the muscles and tendons are attached. Bone is living tissue that contains nerves and receives oxygen and nutrients from the arterial system. When a bone breaks, a patient typically experiences severe pain and bleeding. A joint is formed wherever two bones come into contact. Joints are held together in a tough, fibrous structure known as a capsule, which is supported and strengthened in certain key areas by bands of fibrous tissue called ligaments. In moving joints, the end of the bones are covered with a thin layer of cartilage known as articular cartilage. Joints are bathed and lubricated by synovial fluid or joint fluid. Joints allow circular motion, shoulder, hinge motion, knee and elbow, and minimum motion, the sacral and sternoclavicle joints, or no motion structures in the skull. Musculoskeletal injuries. Injury to bones and joints is often associated with injury to the surrounding soft tissues, known as the zone of injury. Mechanism of injury, MOI. Significant force is generally required to cause fractures and dislocations. Direct blows, indirect forces, twisting forces, high energy forces. A direct blow fracture to the bone at the point of impact. Indirect force may cause a fracture or dislocation at a distant point. Twisting forces are a common cause of musculoskeletal injury, especially to the anterior clavicle ligament or metatarsal ligament in the knee, the ACL and the MCL. High-energy injuries produce severe damage to the skeleton surrounding soft tissue and vital internal organs. A patient may have multiple injuries to many body parts. Can occur in automobile crashes, falls from heights, gunshot wounds, and other extreme forces. A significant MOI is not always necessary to fracture a bone. A slight force can easily fracture a bone that is weakened by a tumor, infection, or osteoporosis. Fractures. A fracture is a break in the continuity of a bone, often occurring as a result of an extreme external force. Can occur anywhere on the surface of the bone and in many different types of patterns. There is no difference between a broken bone and a fractured bone. A potential complication of fractures is compartment syndrome, elevated pressure within the facial compartment. Fractures are classified as either closed or opened. Your first priority is to determine whether the overlying skin is damaged. If not, the patient has a closed fracture. With an open fracture, there is an external wound, caused either by the same blow that fractured the bone or by the broken bone ends lacerating the skin. You should treat any injury that breaks the skin as a possible open fracture. Complications of open fractures include increased blood loss and higher likelihood of infection. Fractures are also described by whether the bone is moved from its normal position. A non-displaced fracture, also known as a hairline fracture, is a simple crack of the bone that may be difficult to distinguish from a sprain or simple contusion. Radiograph examinations are required. A displaced fracture produces an actual deformity or dislocation of the limb by shortening, rotating, or angling it. Medical personnel often use special terms to describe particular types of fractures. Communicated, a fracture in which the bone is broken into two or more fragments. Physiology, a fracture that occurs in a growth section of a child's bone and may lead to growth abnormalities. A green stick, an incomplete fracture that passes only partway through the shaft of a bone. This occurs in children. Incomplete, a fracture that does not run completely through the bone. Oblique, a fracture in which the bone is broken at an angle across the bone, usually as a result of a sharp angled blow to the bone. Pathologic, a fracture of weakened or diseased bone generally produced by minimal force. This is seen in patients with osteoporosis or cancer. Spiral, a fracture caused by a twisting force, causing an oblique fracture around the bone and through the bone, often a result of abuse in very young children. Transverse, a fracture that occurs straight across the bone, usually the result of a direct blow or stress fracture caused by prolonged running. Suspect a fracture if one or more of the following signs are present. Deformity. The limb may appear to be shortened, rotated, or angled at a point where there is no joint. Always use the opposite uninjured limb as a mirror image for comparison. Tenderness. Point tenderness on palpation in the zone of injury is the most reliable indicator of underlying fractures. Guarding. An inability to use the extremity in the patient's way of immobilizing it to minimize pain. The muscles around the fracture contract in an attempt to prevent any movement of the broken bone. Swelling. Rapid swelling usually indicates bleeding from a fracture and typically followed by substantial pain. Bruising. Fractures are almost always associated with epidermis of the surrounding soft tissues. Bruising may be present after almost any injury and may take hours to develop. Crepitus. A grating or grinding sensation can be felt and sometimes even heard when fractured bone ends rub together. False motion. Motion at a point in the limb where there is no joint. Exposed fragments. In open fractures, bone ends may protrude through the skin or be visible within the wound. Never attempt to push the end of a protruding bone back into place. And pain. A locked joint. A joint that is locked into position is difficult or painful to move. Dislocations. A disruption of a joint in which the bone ends are no longer in contact. The supporting ligaments are often torn, usually completely, allowing the bone ends to separate completely from each other. A fracture dislocation is a combination injury at the joint in which the joint is dislocated and there is a fracture of the end of one or more of the bones. Sometimes a dislocated joint will spontaneously reduce or return to its normal position before your assessment. You will be able to confirm the dislocation only by taking a patient history. A dislocation that does not spontaneously reduce is a serious problem. Commonly dislocated joints include fingers, shoulder, elbow, and knee. The signs and symptoms of a dislocated joint are similar to those of a fracture. Marked deformity, swelling, pain that is aggravated by any attempt at movement, tenderness upon palpation, virtually complete loss of normal joint motion, locked joint, numbness or impaired circulation to the limb or digit. Sprains. A sprain occurs when a joint is twisted or stretched beyond its normal range of motion. As a result, the supporting capsule and ligaments are stretched or torn. A sprain should be considered a partial dislocation. Sprains can range from mild to severe. The most vulnerable joints are knees, shoulders, and ankles. After the injury, the alignment generally returns to a fairly normal position. Sprains do not usually involve deformity, and joint mobility is limited by pain but not joint continuity. The following signs and symptoms often indicate that the patient may have a sprain. The patient is unwilling to use the limb, guarding, swelling, and ecchymosis. Pain prevents the patient from moving or using the limb. Instability of the joint. You will frequently not be able to distinguish a non-displaced fracture from a sprain. Remember to document the MOI. Strain. A strain pulled muscle is a stretching or tearing of the muscle, causing pain, swelling, and bruising of soft tissues in the area. It occurs because of an abnormal contraction or from exercise of excessive stretching. Strains may require from minute separation to complete rupture. Unlike a sprain, no ligament or joint damage typically occurs. Often no deformity is present and only minor swelling is noted at the site of injury. Some patients may complain of increased pain with passive movement of the injured extremity. Most patients will have extreme point tenderness. Amputations. An amputation is an injury in which an extremity. Complications. Orthopedic injuries can lead to numerous complications, not just those involving the skeletal system, but also systematic changes or illnesses. It is essential that you do not focus all your attention on the skeletal injury. The likelihood of having a complication is often related to the strength of the force that caused the injury, injury's location, and the patient's overall health. To prevent contamination following an open fracture, you should brush away any obvious debris on the skin surrounding the open fracture before applying a dressing. Do not enter or probe the open fracture site. Long-term disability is one of the most devastating consequences of an orthopedic injury. You can help reduce the risk or duration of long-term disability by preventing further injury, reducing the risk of wound infection, minimizing pain by use of cold and analgesia, transporting patients to an appropriate medical facility. Assessing the severity of an injury. The golden period is critical not only for life but also for preserving limb viability. In an extremity with anything less than complete circulation, prolonged hypoperfusion can cause significant damage. Any suspect open fracture or vascular injury is considered a critical emergency. Remember that most injuries are not critical. You can use the musculoskeletal injury grading system in Table 31-1 to identify critical injuries. Patient assessment. Always look at the bigger picture, evaluating the overall complexity of the situation to determine and treat any life threats. You must be able to distinguish mild injuries from severe injuries, because some severe injuries may compromise neurovascular function, which could threaten long-term function. Scene size up. Scene safety. Information from dispatch may indicate the MOI, the number of patients involved, and the first aid procedures used prior to your arrival. Try to identify the forces associated with the MOI. Standard precautions may be as simple as gloves, but a mask and gown may be necessary. Consider the possibility that there may be hidden bleeding. Evaluate the need for law enforcement support, advanced life support, or additional ambulances. Mechanism of injury, nature of illness. Look for indicators of the MOI. Be alert for both primary and secondary injuries. Primary injuries occur as a result of the MOI. Secondary injuries are a result of what happens after the initial injury. Consider what injuries the MOI would lead you to expect. Primary assessment. Focus on identifying and managing life threats. Treating the patient according to his or her level of consciousness and ABCs is always a priority. Address significant internal or external bleeding and treat for shock. Check for responsiveness using the AVPU scale. Ask the patient about his or her chief complaint. Administer high-flow oxygen via a non-rebreather mask or a BVM to all patients whose level of consciousness is less than alert and oriented. Ask about the MOI. If there was significant trauma and multiple body systems are affected, the musculoskeletal injuries may be a lower priority. Scene time should not be wasted on prolonged musculoskeletal assessment or splinting. Airway and breathing. Fractures and sprains usually do not create airway and breathing problems. Little else matters if the patient's airway and breathing are inadequate. Circulation. Focus on determining whether the patient has a pulse, has adequate perfusion, or is bleeding. Hypoperfusion and bleeding problems will most likely be your primary concern. If the skin is pale, cool, or clammy and capillary refill time is slow, treat your patient for shock immediately. Maintain a normal body temperature. If musculoskeletal injuries in the extremities are suspected, they must be at least initially stabilized, if not splinted, prior to moving. Transport decision. If the patient you are treating has an airway or breathing problem or significant bleeding, provide rapid transport to the hospital for treatment. A patient who has a significant MOI but whose condition appears otherwise stable should also be transported promptly. When a decision for rapid transport is made, you can use a backboard as a splinting device to splint the whole body rather than splinting each extremity individually. Individual splints should be applied en route if the ABCs are stable and time permits. Patients with a simple MOI may be further assessed and their condition stabilized on scene prior to transport if no other problems exist. Fractures can break through the skin and cause external bleeding. Carefully handling of the extremity minimizes this risk. If external bleeding is present, bandage the extremity quickly to control bleeding. The bandage should be secure enough to control bleeding without restricting circulation distal to the injury. Monitor bandage tightness by assessing the circulation, sensation, and movement distal to the bandage. If bleeding cannot be controlled, quickly apply a tourniquet. History taking. Obtain a medical history and be alert for injury-specific signs and symptoms and patent negatives. Obtain a sample history for all trauma patients. How much and in what detail you explore this history depends on the seriousness of the patient's condition and how quickly you need to transport him or her to the hospital. Make an attempt to obtain this history without delaying time to definitive care. OPQRST can be of limited use in cases of severe injury and is usually too lengthy when matters of airway, breathing, circulation, and rapid transport require immediate attention. It may be useful when the MOI is unclear, the patient's condition is stable, or details of the injury are uncertain. Secondary assessment. Physical examinations. If significant trauma has likely affected multiple systems, start with the secondary assessment of the entire body to be sure you found all of the problems and injuries. Begin with the head and work systematically towards the feet, checking the head, chest, abdomen, and extremities and back. The goal is to identify hidden and potentially life-threatening injuries. Use DCAP BTLS approach to assess the musculoskeletal system. When lacerations are present in an extremity, an open fracture must be considered, bleeding controlled, and dressings applied. If your assessment finds no external signs of injury, ask the patient to move each limb carefully, stopping immediately if movement causes pain. Skip this step if the patient reports neck or back pain. When non-significant trauma has occurred and you suspect that the patient has a simple strain, sprain, dislocation, or fracture, you can take the time to focus your secondary assessment on that particular injury. Look for DCAP BTLS. Evaluate the circulation, motor function, and abnormal sensations distal to the injury. Be sure to assess the entire zone of injury. Any injury or deformity of bone may be associated with vessel or nerve injuries. You must assess the neurovascular function every 5 to 10 minutes during the assessment, depending on the patient's condition, until he or she is in the hospital. Always recheck the neurovascular function before and after you splint or otherwise manipulate a limb. Examination of the injured limb should include the 6 P's of musculoskeletal assessment: pain, paralysis, paracentesis, numbness or tingling, pulselessness, pallor, and pressure. Vital signs. Determine a baseline set of vital signs including pulse rate, rhythm, and quality, respiratory rate, rhythm, and quality, blood pressure, skin condition, and pupil size, and reaction to light. Trending these vital signs helps you to understand whether your patient's condition is improving or getting worse over time. Reassessment. Repeat the primary assessment to ensure your interventions are working as they should. A reassessment should be performed every 5 minutes for an unstable patient and every 15 minutes for a stable patient. Interventions. Because trauma patients often have multiple injuries, you must assess their overall condition, stabilize the ABCs, and control any serious bleeding. In a critically injured patient, you should secure the patient to a long backboard to immobilize the spine, pelvis, and extremities and provide prompt transport to a trauma center. In this situation, a secondary assessment is a waste of valuable time. Reassess the patient en route to the emergency department. If the patient has no life-threatening injuries, you may take extra time at the scene to stabilize the patient's overall condition. Remove the patient's clothing to look for open fractures or dislocations, severe deformity, swelling, and/or ecchymosis. When you have finished assessing the extremity, apply a splint, secure splint, commercial or otherwise, to stabilize the injury prior to transport. A complete and secure splint will reduce pain, reduce shock, and minimize compromised circulation. Check the patient's circulation, motor function, and sensation prior to and after splinting. The main goal is providing care in musculoskeletal injuries is stabilization in the most comfortable position that allows for maintenance of good circulation distal to the injury. Communication and documentation. Include a description of the problems found during your assessment, report problems with the patient's ABCs, open fractures, and compromised circulation that occurred before or after splinting. Document complete descriptions of injury and MOI associated with them. Your careful documentation may protect you from legal action that patients may take later. Emergency medical care. Perform a primary assessment and stabilize the patient's ABCs. If needed, perform a secondary assessment of either the entire body or the specific area of injury. Always follow standard precautions. Be alert for signs and symptoms of internal bleeding. Follow the steps in Skill Drill 31-1 when caring for patients with musculoskeletal injuries. Splinting. A splint is a flexible or rigid device that is used to protect and maintain the position of an injured extremity. Unless the patient's life is in immediate danger, you should splint all fractures, dislocations, and sprains before moving the patient. Splinting reduces pain and makes it easier to transfer and transport the patient. In addition, splinting will help to prevent the following: further damage to muscles and the spinal cord, peripheral nerves, and blood vessels from broken bone ends, laceration of the skin by broken bone ends. One of the primary indications for splinting is to prevent a closed fracture from becoming an open fracture, restriction of distal blood flow resulting from pressure of the bone ends on blood vessels, excessive bleeding of the tissue at the injury site caused by broken bone ends, increased pain from movement of the bone ends, paralysis of the extremity resulting from damaged spine. A splint is simply a device to prevent motion of an injured part. It can be made from any material on occasions when you need to improvise. The three basic types of splints are rigid, formable, and traction splints. General principles of splinting. Remove clothing from the area of any suspected fracture or dislocation so that you can inspect the extremity for decap VTLS. Note and record the patient's neurovascular status distal to the site of the injury, including pulse, sensations, and movement. Cover open wounds with dry, sterile dressings before splinting. Do not move the patient before splinting an extremity unless there is an immediate danger to the patient or you. In a suspected fracture of the shaft of any bone, be sure to stabilize the joints above and below the fracture. With injuries in and around the joint, be sure to stabilize the bones above and below the injured joint. Pad all rigid splints to prevent local pressure and discomfort to the patient. While applying a splint, maintain manual stabilization to minimize movement of the limb and support the injury site. If the fracture of a long bone shaft has resulted in severe deformity, use constant, gentle manual traction to align the limb so that it can be splinted. If you encounter resistance to limb alignment, splint the limb in its deformed position. Immobilize all suspected spinal injuries in a neutral, in-line position on a backboard. If the patient has signs of shock, align the limb in normal atomic position and provide transport. When in doubt, splint. Rigid splints. Rigid, non-formable splints are made from firm material and are applied to the sides, front, and or back of an injured extremity to prevent motion at the injury site. It takes 2 EMTs to apply a rigid splint. Follow steps in Skill Drill 31-2. There are 2 situations in which you must splint the limb in the position of deformity. When the deformity is severe, when you encounter resistance or extreme pain when applying gentle traction to the fracture or shaft of a long bone. Most dislocations should be splinted as found, but follow local protocols. Formable splints. The most commonly used splints are soft splints, is the pre-contoured inflatable clear plastic air splint. Always inflate the splint after applying it. The air splint is comfortable, provides uniform contact, and has the added advantage of applying firm pressure to a bleeding wound. Air splints are used to stabilize injuries below the elbow and below the knee. splints have some drawbacks, particularly in cold weather areas. The zipper can stick, clog with dirt, or freeze. Significant changes in the weather or altitude can affect the pressure of the air in the splint. You must first cover all wounds with dry, sterile dressings, making sure that you use standard precautions. For a splint that has a zipper, follow steps in skill drill 31-3. If you use an unzippered or partially zippered type of air splint, follow the steps in skill drill 31-4. Other formable splints include vacuum splints, pillow splints, structural aluminum, malleable splints, a sling or swath, and pelvic binders for pelvic fractures. Follow the steps in skill drill 31-5 to apply a vacuum splint. Traction splints. Application of inline traction is the act of pulling on a body structure in the direction of its normal alignment. It is the most effective way to realign a fracture of the shaft of a long bone so that the limb can be splinted more effectively. Traction splints are used primarily to secure fractures of the shaft of the femur, which are characterized by pain, swelling, and deformity of the mid-thigh. When applied correctly, traction stabilization of the bone fragments improves the overall alignment of the limb. Do not attempt to force the bone fragments back into alignment. In the field, the goal of inline traction are as follows: to stabilize the fracture fragments to prevent excessive movement, to align the limb sufficiently to allow it to be placed in a splint, to avoid potential neurovascular compromise. Do not use traction splints for any of the following conditions: injuries to the upper extremity, injuries close to or involving the knee, injuries of the pelvis, partial amputations or avulsion with bone separation, lower leg, foot, or ankle injury. Proper alignment requires 2 EMTs. Before you apply a traction splint, be sure to control any excessive bleeding. The amount of traction that is required varies, but often does not exceed 15 pounds. You should use the least amount of force necessary. Grasp the foot or hand at the end of the injured limb firmly. Once you start pulling, you should not stop until the limb is fully splinted. Imagine where the uninjured limb would lie and pull gently along the line of that imaginary limb until the injured limb is in approximately that position. If the patient strongly resists the traction or it causes more pain that persists, stop and splint the limb in the deformed position. To apply a hair splint, follow the steps in skill drill 31-6. The Sager splint is lightweight and easy to store and applies a measurable amount of traction and can be applied by one person if necessary. Follow the steps in skill drill 31-7 to apply a Sager splint. Pelvis binders. Pelvic binders are used to splint the bony pelvis to reduce hemorrhage from bone ends, venous disruption, and pain. Pelvic binders are meant to provide temporary stabilization until definitive stabilization can be achieved. Generally, pelvic binders should be lightweight, made of soft material, and easily applied by one person, and they should allow access to the abdomen, peritoneum, anus, groin for examination. Hazards of improper splinting: compression of nerves and tissues, blood vessels, delay in transport of a patient with life-threatening injury, reduction of distal circulation, aggravation of the injury to tissues, nerves, blood vessels, or muscles as a result of excessive movement of bone or joint. Transportation. Very few, if any, musculoskeletal injuries justify the use of excessive speed during transport. The limb will be stable once a dressing and splint has been applied. A patient with a pulseless limb must be given a higher priority. If the treatment facility is an hour or more away, a patient with a pulseless limb should be transported by helicopter or immediate ground transportation. Specific musculoskeletal injuries. Injuries to the clavicle and scapula. The clavicle or collarbone is one of the most commonly fractured bones in the body. Fractures of the clavicle often occur commonly in children when they fall on an outstretched hand. A patient with a fracture of a clavicle will report pain in the shoulder and will usually hold the arm across the front of his or her body. Generally, swelling and point tenderness occur over the clavicle. Because the clavicle is supercutaneous, the skin will occasionally tent over the fracture fragment. Fractures of the scapula or shoulder blade occur much less frequently because the bone is well protected by large muscles. Fractures of the scapula are almost always a result of a forceful direct blow to the back directly over the scapula. Provide supplemental oxygen and prompt transport for patients who are having difficulty breathing. It is the associated chest injuries, not the fractured scapula itself, that pose the greatest threat to long-term disability. Abrasions, contusions, and significant swelling may occur, and the patient will often limit use of the arm because of pain at the fractured site. The joint between the outer end of the clavicle and the acromion process of the scapula is called the acromion-clavicle joint, the AC. This joint is frequently separated during sports following, such as football or hockey, when the player falls and lands on the point of the shoulder, driving the scapula away from the outer end of the clavicle. This dislocation is often called an AC separation. These fractures can all be splinted effectively with a sling and swath. A sling is any bandage or material that helps prevent the weight of the injured upper extremity, relieving the downward pull of gravity on the injury site. To fully stabilize the shoulder region, a swath, which is a bandage that presses completely around the chest, must be used to bind the arm to the chest wall. Leave the patient's fingers exposed so you can assess neurovascular function at regular intervals. Dislocation of the shoulder. The glenohumeral shoulder joint, is where the head of the humerus meets the genoid fossa of the scapula. The genoid fossa joins with the humeral head to form the genohumeral joint. In shoulder dislocations, the humeral head most commonly dislocates anteriorly, coming to lie in front of the scapula as a result of forced abduction and external rotation of the arm. Shoulder dislocations are extremely painful. The patient will guard the shoulder and try to protect it by holding the dislocated arm in a fixed position away from the chest wall. The shoulder joint will usually be locked, and the shoulder will appear squared off or flattened. Some patients may report numbness in the hand because either nervous or circulatory compromise. Stabilizing an anterior shoulder dislocation is difficult because any attempt to bring the arm in toward the chest wall produces pain. You must splint the joint in whatever position is most comfortable for the patient. If necessary, place a pillow or rolled blankets or towel between the arm and the chest to fill up the space and stabilize the arm. Apply a sling to the forearm and wrist to support the weight of the arm. Secure the arm in the sling to the pillow and chest with a swath. Transport the patient in a seated or semi-seated position. Fractures of the humerus. Fractures of the humerus occur either proximally in the midshaft or distally at the elbow. Fractures of the proximal humerus resulting from falls are common among older people. Fractures of the midshaft occur more often in young patients, usually as a result of a violent injury. With any severely angulated fracture, you should consider applying traction to realign the fracture fragments before splinting them. Support the site of the fracture with one hand, and with the other hand grasp the two humeral cardides just above the elbow. Pull gently in line with normal access of the limb. Splint the arm with a sling and swath, supplemented by a padded board splint on the lateral aspect of the arm. Elbow injuries. Fractures and dislocations often occur around the elbow, and the different types of injuries are difficult to distinguish without radiographic examinations. They all produce similar limb deformities and require the same emergency care. Fracture of the distal humerus is this type of fracture, also known as a supracondyle or intracondyle fracture, is common in children. Frequently, the fracture fragments rotate significantly, producing deformity and causing injuries to nearby vessels and nerves. Swelling occurs rapidly and is often severe. Dislocation of the elbow. This type of injury typically occurs in athletes and rarely in young children. The ulna and radius are most often displaced posteriorly relative to the humerus. The posterior displacement makes the ulna cannon process of the ulna much more prominent. As with a fracture of the distal humerus, there is swelling and significant potential for vessel or nerve injury. Elbow joint sprain. This diagnosis is often mistakenly applied to the occult non-displaced fracture of the cannon process of the ulna. This fracture can result from direct or indirect forces and is often associated with lacerations and abrasions. The patient will be unable to actively extend the elbow. Fractures of the radial head. Often missed during diagnosis, this fracture generally occurs as a result of a fall on an outstretched arm or a direct blow to the lateral aspect of the elbow. Attempts to rotate the elbow or wrist cause discomfort. Care of elbow injuries. All elbow injuries are potentially serious and require careful management. Always assess distal neurovascular functions periodically in patients with elbow injuries. If you find strong pulses and good capillary refill, splint the elbow injury in the position in which you found it, adding a wrist splint if this seems helpful. A cold, pale hand or weak or absent pulse and poor capillary refill indicate that the blood vessels have likely been injured. Further care of this patient must be directed by a physician. Notify medical control immediately. If the limb is pulseless and significantly deformed at the elbow, apply gentle manual traction in line with the long axis of the limb to decrease the deformity. Provide prompt transport for all patients with impaired distal circulation. Fractures of the forearm. Fractures of the shaft of the radius and ulna are common in people of all age groups, but are seen most often in children and older people. Usually both bones break at the same time when the injury is a result of a fall on an outstretched hand. An isolated fracture of the shaft of the ulna may occur as a result of a direct blow to it, a nightstick fracture. Fractures of the distal radius, which are especially common in elderly patients with osteoporosis, are also known as Colles fractures. The term the silver fork deformity is used to describe the distinctive appearance of a patient's arm. To stabilize fractures of the forearm or wrist, you can use a padded board, air vacuum, or pillow splint. If the shaft of the bone has been fractured, be sure to include the elbow joint in the splint. If possible, elevate the injured extremity above the heart to help alleviate swelling. Injuries of the wrist and hand. Injuries of the wrist, ranging from dislocations to sprains, must be confirmed by radiograph examination. Dislocations are usually associated with a fracture resulting in a fracture dislocation. Another common wrist injury is the isolated, non-displaced fracture of the carpal bone, especially the scaphoid. Any questionable wrist sprain or fracture should be splinted and elevated in the emergency department. Hand injuries vary widely, some with potential serious consequences. Because the fingers and hands are required to function in such intricate ways, any injury that is not treated properly may result in permanent disability, as well as deformity. For this reason, all injuries to the hand, including simple lacerations, should be evaluated by a physician. Do not attempt to pop a dislocated finger joint back into place. Always take any amputated parts to the hospital with the patient. Follow the steps in skill drill 31-8 to splint the hand and wrist. Fractures of the pelvis. Fracture of the pelvis often result from direct compression in the form of a heavy blow that laterally crushes the pelvis. The blow may be from a motor vehicle crash, a weapon, a falling object, or a fall from a height. Injuries to the pelvis can also be caused by indirect forces. However, not all pelvis fractures result from violent trauma. Fractures of the pelvis may be accompanied by life-threatening loss of blood from the laceration of blood vessels affixed to the pelvis at certain key points. Up to several liters of blood may drain into the pelvic space and the retroperitoneal space, which lies between the abdominal cavity and the posterior abdominal wall. The result is significant hypotension, shock, and sometimes death. You must take immediate steps to treat shock, even if there is only minimal swelling. Because the pelvis is surrounded by heavy muscle, open fractures of the pelvis are uncommon. However, pelvis fracture fragments can lacerate the rectum and vagina, creating an open fracture that is often overlooked. You should suspect a fracture of the pelvis in any patient who has sustained a high-velocity injury and complains of discomfort in the lower back or abdomen. Deformity or swelling may be very difficult to see. The most reliable sign of fracture of the pelvis is simple tenderness or instability on firm compression and palpation. Access for tenderness by taking the following steps. Place the palms of your hand over the lateral aspect of the iliac crest. Apply firm but gentle inward pressure on the pelvic ring. With the patient lying supine, place a palm over the anterior aspect of each iliac crest to apply firm downward pressure. Use the palm of your hand to firmly but gently palpate the pubic symphysis. If there has been an injury to the bladder or urethra, the patient will have lower abdominal tenderness and may have evidence of hematuria or blood at the urethral opening. Patients in stable condition can be secured to a long backboard or a scoop stretcher to stabilize isolated fractures of the pelvis. The figure on this slide shows how to assess the pelvic region for tenderness and instability. Dislocations of the hip. The hip is a very stable ball and socket joint that dislocates only after significant injury. Most dislocations of the hip are posterior, most common occurring as a result of motor vehicle crash, in which the knee meets with a direct force and the entire femur is driven posteriorly. You should suspect a hip dislocation in any patient who has been in an automobile crash and has a contusion, laceration, or obvious fracture in the knee region. Posterior dislocation of the hip is frequently complicated by injury to the sciatic nerve, which is located directly behind the hip joint. The sciatic nerve is the largest nerve in the lower extremity. It controls the activity of muscles in the posterior thigh and below the knee and the sensation in most of the leg and foot. When the head of the femur is forced out of the hip socket, it may compress or stretch the sciatic nerve, leading to partial or complete paralysis of the nerve. Patients typically lie with the hip joint flexed and the thigh rotated inward toward the midline of the body over the top of the opposite thigh. With the less common anterior dislocation, the limb is in the opposite position, extended out, externally rotated, and pointed away from the midline of the body. Dislocation of the hip is associated with very distinctive signs. The patient will have severe pain in the hip and will strongly resist any attempt to move the joint. The lateral and posterior aspect of the hip region will be tender on palpation. Occasionally, sciatic nerve function will be normal at first and then slowly diminish. As with any other extremity injury, do not attempt to reduce the dislocated hip in the field unless medical control directs you to do so. Splint the dislocation in the position of the deformity. Place the patient supine on a long backboard. Support the unaffected limb with pillows and rolled blankets. Secure the entire limb to the backboard with long straps. Provide prompt transport. Fractures of the proximal femur. Fractures of the proximal end of the femur are common fractures, especially in older people and patients with osteoporosis. The break goes through the neck of the femur, the introchiatic region, or across the proximal shaft of the femur. Patients display a very characteristic deformity. They lie with their leg externally rotated, and the injured limb is usually shorter than the opposite uninjured limb. Patients typically are unable to walk or move the leg. The hip region is usually tender on palpation, and gentle rolling of the leg will cause pain, but will do no further damage. Assess the pelvis for any soft tissue injury and bandage appropriately. Assess pulses and motor and sensory function, looking for signs of vascular and nerve damage. Splint the lower extremity and transport to the emergency department. The age of the patient and severity of the injury will dictate how you splint the fracture. All patients with hip fractures may lose significant amounts of blood. You should treat with high-flow oxygen and monitor vital signs frequently. Be alert for signs of shock. Femoral shaft fractures. Fractures to the femur can occur in any part of the shaft, from hip region to the femoral condyles just above the knee joint. Following a fracture, the large muscle of the thigh spasm in attempt to splint the unstable limb. The muscle spasm often produces significant deformities in the limb. Usually the limb also shortens significantly. Fractures may be open, the fragments of the bone may protrude through the skin. Never attempt to push the bones back into the skin. There is often significant amount of blood loss, as much as 500 to 1,000 milliliters after a fracture. It is not unusual for hypervolemic shock to develop. Because of severe deformity that occurs with these fractures, bone fragments may penetrate or press on important nerves and vessels and produce significant damage. You must carefully and periodically assess the distal neurovascular function in these patients. Cover any wound with dry, sterile dressing. If the foot or leg below the level of fracture shows signs of impaired circulation, apply gentle longitude traction to the deformed limb in line with the long axis and gradually turn the leg from the deformed position. A fracture of the femoral shaft is best stabilized with a traction splint, such as the Sager splint. Injuries to the knee ligaments. The knee is very vulnerable to injury. Therefore, many different types of injuries occur in this region. Ligament injuries range from mild sprains to complete dislocations of the joint. The patella can also dislocate. All the bony elements of the knee can fracture. The knee is especially susceptible to ligament injuries, which often occur when abnormal bending or twisting forces are applied to the joint. When you examine the patient, you will generally find swelling, occasional echomeresis, point tenderness at the injury site, joint avulsion. You should splint all suspected knee ligament injuries. The splint should extend from the hip joint to the foot, stabilizing the bone above the injured joint and below it. A variety of splints can be used, including a padded, rigid, long leg splint or 2 padded board splints. Dislocation of the knee. Dislocations of the knee are true emergencies that may threaten the limb. When the knee is dislocated, the ligaments that provide support to it may be torn or damaged. The proximal end of the tibia completely displaces from the juncture with the lower end of the femur, usually producing a significant deformity. Always check the distal circulation carefully before taking any other step. The direction of the dislocation refers to the position of the tibia with respect to the femur. Posterior knee dislocations are most common, occurring in almost half of all cases. Commonly, the anterior and posterior cercolite ligaments are damaged, but there is also a high risk of injury to the postlateral artery. Medial dislocations result from a direct blow to the lateral part of the leg. Patients will typically complain of pain in the knee and report that the knee gave out. Complications may include limb-threatening potential artery disruption, injuries to the nerve, joint instability. If adequate distal pulses are present, splint the knee in the position in which you found it and transport the patient promptly. Fractures about the knee. Fractures about the knee may occur at the distal end of the femur, at the proximal end of the tibia, or in the patella. It is easy to confuse a non-displaced or minimally displaced fracture about the knee with a ligament injury. Management of the two types of injuries are as follows. If there is an adequate distal pulse and no significant deformity, splint the limb with the knee straight. If there is adequate pulses and significant deformity, splint the joint in the position of deformity. If the pulse is absent below the level of injury, suspect possible vascular and nerve damage and contact medical control. Never use a traction splint if you suspect a fractured knee. Dislocation of the patella. A dislocated patella most commonly occurs in teenagers and young adults who are engaged in athletic activities. Usually the dislocation patella displaces to the lateral side. The displacement produces a significant deformity in which the knee is held in a moderately flexed position. The patella is dislocated to the lateral side of the knee. Splint the knee in the position in which you found it. Most often this is with the knee flexed to a moderate degree. Apply padded board splints to the medial and lateral aspects of the joint, extending from hip to ankle. Injuries of the tibia and fibula. Fracture of the shaft of the tibia or fibula may occur at any place between the knee joint and the ankle joint. Often both bones fracture at the same time. Even a single fracture may result in a severe deformity with significant angulation or rotation. Open fractures of the tibia are relatively common. These fractures should be stabilized with padded rigid long leg splint or an air splint that extends from the foot to the upper thigh. Correct severe deformity before splinting by applying gentle longitude traction. These fractures are sometimes associated with vascular injury as a result of distorted position of the limb following injury. Realigning the limb frequently restores the adequate blood supply to the foot. If it does not, transport promptly and notify medical control. Ankle injuries. The ankle is a commonly injured joint. Ankle injuries occur in people of all ages and range in severity from a simple sprain to a severe fracture dislocations. Any ankle injury that produces pain, swelling, localized tenderness, or the inability to bear weight must be evaluated by a physician. The most frequent mechanism of ankle injury is twisting, which stretches or tears the supporting ligaments. You can manage the wide spectrum of injuries to the ankle in the same way as follows. Dress any open wounds, assess distal neurovascular function, correct any gross deformity by applying gentle longitude traction to the heel. Before releasing traction, apply a splint. Foot injuries. Injuries to the foot can result in the dislocation or fracture of one or more of the tarsal, metatarsals, or phalanges of the toes. Toe fractures are especially common. Of the tarsal bones, the heel bone is the most frequently fractured. Injury often occurs when a patient falls or jumps from a height and lands directly on the heel. Frequently, the force of injury is transmitted up the leg to the spine, producing a fracture of the lumbar spine. If you suspect that the foot is dislocated, immediately assess for pulses and motor and sensory functions. If pulses are present, immobilize the extremity using commercially applied available splint. If the splint Pulses are absent. Contact medical control. Injuries of the foot are associated with significant swelling but rarely with gross deformity. Vascular injuries are not common. Lacerations about the ankle and foot may damage important underlying nerves and tendons. Puncture wounds of the foot are common and may cause serious infection if not treated early. To splint the foot, apply a rigid padded war splint, air splint, or pillow splint, stabilizing the ankle joint and the foot. Leave the toes exposed. When the patient is lying on the stretcher, elevate the foot approximately 6 inches to minimize swelling. Strains and sprains. Treat every severe sprain as if it was a fracture. General treatment is similar to that of fractures and includes RICEs: rest, ice, compression, elevation, and splinting. Amputations. Control bleeding and treat for shock. Surgeons today can occasionally reattach amputated parts. With partial amputations, make sure to immobilize the part with bulky compressive dressings and splint to prevent further injury. Do not sever any partial amputations. Control any bleeding from the stump. If bleeding is severe, quickly apply a tourniquet. With a complete amputation, make sure to wrap the clean part of a sterile dressing and place it in a plastic bag. Follow local protocols regarding how to preserve amputated parts. Put the bag in a cooled container filled with ice. The goal is to keep the part cool without allowing it to freeze or develop frostbite. The amputated part should be transported with the patient to the appropriate resource hospital. Compartment syndrome. Compartment syndrome most often occurs with fractured tibia or forearm of children, often overlooked, especially in patients with an altered level of consciousness. Compartment syndrome typically develops within 6 to 12 hours after injury, usually a result of excessive bleeding, a severely crushed extremity, the rapid return of blood to an ischemic limb. The syndrome is characterized by pain that is out of proportion to the injury, pain or passive stretching of muscles within the compartment, pallor, decreased sensation, decreased power. If you have a pediatric patient with a fracture below the elbow or knee, be on the lookout for these signs and symptoms: extreme pain, decreased pain sensation, pain on stretching of affected muscles, decreased power. These are indicators that the pressure within the facial compartment is elevated. If you suspect the patient has compartment syndrome, splint the affected limb, keeping it at level of the heart, and provide immediate transport. Reassess neurovascular status frequently during transport. Okay, class, let's go over a few review questions. Review question 1. Skeletal muscle is also referred to as A. Smooth muscle, B. Striated muscle, C. Autonomic muscle, D. Involuntary muscle. The correct answer is B. Skeletal muscle, also called striated muscle because of its characteristic stripes or striations, attaches to the bones and usually crosses over at least one joint, forming the major muscle mass of the body. This type of muscle is also called voluntary muscle because it is under direct voluntary control of the brain. Answer A. Smooth muscle. This is found in the walls of most tubular structures, internal organs, and the cardiovascular system. Answer B is the correct answer. Answer C. This is not a term associated with muscles. D. Involuntary muscles is also called smooth muscle. It is not under voluntary control of the brain. Review question 2. You respond to a soccer game for a 16-year-old male with severe ankle pain. When you deliver him to the hospital, the physician tells you that he suspects a sprain. This means that A. There is no disruption of the joint and the bone ends are no longer in contact. B. The patient has an incomplete fracture that passes only partway through the bone. C. Stretching or tearing of the ligaments with partial or temporary dislocation of the bone ends has occurred. D. The muscles of the ankle have been severely stretched, resulting in displacement of the bone from the joint. The correct answer is C. A sprain is a joint injury in which there is both partial or temporary dislocation of the bone ends and partial stretching or tearing of the supporting ligaments. Sprains are typically marked by swelling, pain, and echomeresis. Answer A. With a sprain, there will be partial or temporary dislocation of the bone ends. B. With a sprain, there is no fracture associated with the injury. C is the correct answer. D. The muscles of the ankle have been severely stretched, resulting in a displacement of the bones from the joint. A sprain is not an injury to the muscles. Review question 3. A young male has a musculoskeletal injury and is unresponsive. You will not be able to assess A. False motion, B. Distal pulses, C. Capillary refill, D. Sensory and motor functions. The correct answer is D. In order to assess sensory functions and motor functions, i.e. can you feel, can you move, the patient must be conscious, alert, and able to follow commands. False motion, distal pulses, and capillary refill are objective findings, therefore they can be assessed in unresponsive patients. A, B, and C are all objective findings. The correct answer is D. Review question 4. The purpose of splinting a fracture is to A. Reduce the fracture if possible, B. Prevent motion of the bony fragments, C. Reduce swelling in the adjacent soft tissues, D. Force the bony fragments back into atomic alignment. The correct answer is B. The purpose of splinting a fracture is to prevent motion of the bony fragments, thus minimizing the possibility of neurovascular damage. Splinting is not intended to force bony fragments into atomic alignment, nor will it reduce swelling. Ice reduces swelling. You should never try to reduce a fracture. Answer A. Reduction of a suspected fracture is a medical procedure to be performed in the hospital. B is the correct answer. C. Splinting will not reduce swelling, but cold application will. D. Splinting to immobilize a fracture site is not intended to force bony fragments back into alignment. Review question 5. A motorcyclist crashed his bike and has closed deformities to both his midshaft femurs. He is conscious but restless, his skin is cold and clammy, and his radial pulses are rapid and weak. The most appropriate splinting technique of this patient involves A. Applying rigid board splints, B. Applying 2 traction splints, C. Securing him to a long backboard, D. Immobilizing his femurs with air splints. The correct answer is C. In this particular case, it is more practical and less time-consuming to secure the patient to a long backboard. He is in shock and requires rapid transport. Taking the time to apply traction splints, air splints, or board splints will only delay transport. A. This causes undue delays in transport of the patient. B. This also causes undue delays in the transport of the patient. C is the correct answer. D as well causes undue delays in the transport of the patient. Review question 6. To effectively immobilize a fractured clavicle, you should apply A. A sling in a swath, B. An air splint over the entire arm, C. A rigid splint to the upper arm, then a sling, D. Traction splint to the arm of the injured site. The correct answer is A. The quickest and most effective way to immobilize a fractured clavicle is to apply a sling and swath. The sling will help minimize movement of the clavicle itself, while the swath will minimize movement of the arm on the affected side. A is the correct answer. B. An air splint is not effective on a joint. C. A sling will not prevent the movement of the shoulder. D. There is no traction splint for the arm. Review question 7. A patient tripped, fell, and landed on her elbow. She is in severe pain and has obvious deformities to her elbow. You should A. Assess distal pulses, B. Manually stabilize her injury, C. Assess her elbow for crepitus, D. Apply rigid board splints to her arm. The correct answer is B. When caring for a patient with orthopedic injury, you should first manually stabilize the injury site. This will prevent further injury. You should then assess pulses, motor function, and sensory function distal to the injury. Splint the injury using the appropriate technique, and then reassess pulse, motor functions, and sensory functions. Do not intentionally assess for crepitus. This is a coincidental finding that you may encounter during your assessment and should not be elicited. A. This is completed after manual stabilization of the injury. The correct answer is B. C. Do not intentionally assess for crepitus. This is a coincidental finding. D. This is completed after manual stabilization of the injury. Review question 8. When treating an open extremity fracture, you should A. Apply a splint, then dress the wound. B. Dress the wound before applying a splint. C. Irrigate the wound before applying a dressing. D. Allow the material that secures the splint to serve as the dressing. The correct answer is B. Prior to splinting an open wound extremity fracture, you should cover the wound with a dry, sterile dressing. This will help control any bleeding and decrease the risk of infection. Irrigating an open fracture should be avoided in the field. This also increases the risk of infection, especially if foreign material is flushed into the wound. A. The dressing must come before the splint. B is the correct answer. C. Irrigation of an open wound in the pre-hospital setting may increase the chances of infection. D. The wound must be dressed separately from the splint before splinting is done. Review question 9. Which of the following musculoskeletal injuries has the greatest risk for shock due to blood loss? A. Pelvic fracture. B. Posterior hip dislocation. C. Unilateral femur fracture. D. Proximal humerus fracture. The correct answer is A. The pelvic cavity can accumulate a large volume of blood. Shock in a patient with pelvic injury is usually due to the injury of the femoral veins or arteries. Bilateral femur fractures can also cause severe blood loss, up to a liter per femur. A is the correct answer. B. Unless the dislocation has injured the vascular system, bleeding will be contained and minimal. C. A unilateral femur fracture can lose 500 to 1500 milliliters of blood. D. Nerves and blood vessels can be injured and blood loss could be about 500 milliliters. Review question 10. A patient injured her knee while riding a bicycle. She is laying on the ground, has her left leg flexed, is in severe pain, and cannot move her leg. Your assessment reveals obvious deformities to her left knee. Distal pulses are present and strong. The most appropriate treatment for her injury involves A. Wrapping her entire knee area with a pillow. Splinting the leg in the position in which it was found. C. Straightening the leg and applying 2 rigid board splints. D. Splinting her leg and applying and inflating an air splint. The correct answer is B. The patient likely has a dislocated knee. You should immobilize any joint injury in the position in which it was found, especially if distal pulses are present and strong. Attempting to straighten a dislocated joint may cause damage to nerves and/or vasculature. A. Providers can wrap the knee with a pillow to splint it. It is most important to splint the joint in the position it was found. B is the correct answer. C. The straightening of the joint injury is contraindicated if the pulses are intact. D. Air splints are not effective on joint injuries that are flexed. Okay, class, this concludes lecture on Chapter 31, Orthopedic Injuries. If you have any questions or concerns, please contact your instructor, and I will see you in the next chapter.